Hi, good morning, everybody, and thank you for having me. I'm Mark Mittler. I'm the co-chief of Pediatric Neurosurgery at Cohen Children's Medical Center in New York. Kudos to Quinn and to Doctors D'Amico and Langer and Bookvar and the whole team at Lenox Hill for putting this together, because this is just really an amazing endeavor and designed to really inspire the next generation of people to go into fields related to neurosciences. So I thought I'd spend a moment telling you about my story and then transition to talk about a topic that's near and dear to me called craniosynostosis. And it's really essentially a premature fusion of the skull bones that I take care of quite a bit in the New York region. So I grew up in New York. I went to school on Long Island and subsequently went up to the University of Rochester to college. And I thought that I wanted to be pre-med at the time. And while in college, I had the opportunity to use one of my passions of photography and work at a major medical center photographing autopsies. And it was in the height of AIDS, so really in the 80s, and there were very few autopsies being done. So I found myself during a summer job having a lot of spare time. And one of the pathologists in the department said, "Hey, Mark, do you want to learn this technique called teased fiber analysis?" And I said, "Sure." So I went and I learned this technique of teasing out individual axons from nerve biopsies. And I got pretty good at it as a college student. And when I went back to my school in Rochester, I went to the medical center and I said, "Hey, do you guys want to do some teased fiber analysis?" And this is as an undergraduate student. And they scooped me right up and they hired me on the spot in the Department of Neurology to start out some lab stuff with them. And that led to me meeting neurosurgeons, and it led to me being inspired to go on to a field in neurosciences, and doubled down on my studies and was accepted to medical school and stayed in Rochester for medical school, and subsequently became inspired to become a neurosurgeon. So went to Brown University for my internship and my residency, and then was inspired during my residency by a pediatric neurosurgeon, just because I thought the stuff that they did was pretty intense, and went on to a fellowship at Children's Hospital Los Angeles, and then collected my wife and 2 children along the way, and subsequently returned to New York. So now I am practicing essentially in the same hospital that I was born. So a real full circle. I think that throughout the course of all of your journeys, because each of you is going to have a journey, and many of you, probably want to attend some form of health school, such as medical school. I think that my one piece of advice is to create a story about yourself. Make it all make sense, so that when you talk to somebody about your story, you're memorable. And then volunteer for stuff, for extra responsibility. Just stay involved, even if it's not stuff that you're going to get paid for. Even if just do stuff, and you will succeed. I know that Sean Rodgers, my partner, gave you kind of an overview of pediatric neurosurgery last week, and he went through a whole bunch of different things that we do. We take care of a lot of patients with brain tumors, with hydrocephalus, with spinal dysraphism, congenital disorders of the spine. One of the things that we do is take care of something called craniosynostosis. And I'm going to share my screen. So I think you can all see that at this point. Let me know if there's a problem. I don't have the chat up to distract me, but I can do it if, let's see. Okay, got it. I'll take some questions later on towards the end of this. And rather than get, off track, I want to go through a topic that's pretty specific and somewhat unusual. The name of this lecture, I sometimes call it Lumps, Bumps, and Misshapen Heads. I think that, give me one sec. Okay. So we'll call it craniosynostosis and other head shape and size stuff. Great. So back in the 1800s, there was this whole concept of phrenology. And this came about as the detailed study of shape and size of the cranium to indicate character and mental abilities. And this was what is commonly called a pseudoscience, because it really was baloney. Okay, but it's used all the time in various politics and whatnot. And of course, Kanye is trying to figure out himself all the time. But my kids say I can't use this picture because it's too creepy. But I do have a whole series of these misshapen skulls because these are real. This is what happens to children when the skull doesn't form correctly. And one of the recurring themes of this and of brain growth is the concept of craniocephalic proportion. And what that means is that the skull grows to be the shape and the size of the brain for the most part. And there are things that change that. But if we look at this example of a coconut, a pretty good example of what goes on, because inside the middle of the coconut is coconut water or coconut juice and an older coconut. But in any case, with the brain, and this coconut is actually the brain and the shell is actually the skull, it meets the size of the brain. And sometimes if there's extra water, then the whole thing can become bigger. And we'll get to that in a moment. Okay, so the brain growth increases 50% from birth by 2 months of age. Like, it's a dramatic increase. And at 6 months of age, the size of the human brain is essentially twice what it was at birth. And at 10 months, it's 4 times as much. And it just keeps going like that early in infancy. But look what happens as you get to be about 3 years of age. It starts slowing down significantly. Okay. And what we see here is we see this brain growth go up, up, up. And then somewhere in middle age, it starts going down and down and down with some atrophy to various extents. But really 90% of the brain growth is completed by 2 years. So when we take care of infants, we always measure head circumference, because head circumference is a good indication about how the brain is growing. And the head circumference measurement actually corresponds to a chart. And when you were all infants, or if any of you have children, you know that the pediatrician will measure the head and put it on a chart. And that chart is really just a statistical chart. 2 standard deviations above the mean or 2 standard deviations below the mean is what we call abnormal. Okay. Now, there are reasons to have an abnormal head size, and there are reasons to have an abnormal head shape. And we're going to go through some of those things during the course of this talk. But for the most part, we expect most of these children with craniosynostosis to have a head size that's somewhere within the normal range. But there's a concept of macrocephaly. Okay, and with macrocephaly, it means the head size is too big. And there are various causes for macrocephaly, some of which are a problem and some of which just go away on their own. And so when we talk about macrocephaly, one of the most common causes of macrocephaly, or a head circumference that's above the normal range, is something called benign enlargement of the subarachnoid spaces, or BES. And basically, it's a fluid collection that occurs on the outside of the brain in otherwise normal children. And generally speaking, it's self-limited. Right? It's not something that we do a lot of worry about, but those kids have big heads. And so from my perspective, I spend a lot of time reassuring parents that the big head is going to settle down. Okay, but there are other causes of macrocephaly, and one of them, and the main one, is something called hydrocephalus, and that's very different then Bess. Hydrocephalus is where fluid accumulates in the middle of the brain, or the space is called the ventricles. And as you know, throughout the course of this webinar, the ventricles hold cerebrospinal fluid. It's a crystal clear fluid. It's like water. And the brain is constantly producing that water over the course of time. And the choroid plexus, which produces the majority of that cerebrospinal fluid, is located in the brain. So unlike the ventricles of the heart, which pumps around blood but doesn't create blood, the ventricles of the brain, that's where the cerebrospinal fluid is created. And it's a whole separate circulation. And this would be a whole other talk, but what we can see is we can see an ultrasound, and this window here, meaning where the ultrasound is obtained, is directly through that soft spot called the fontanelle. This is a very typical view of a neonatal ultrasound where we see the ventricles, and in this case, the ventricles are enlarged. Another one a little later on where the ventricles are more enlarged, and these kids develop really significant macrocephaly. You can see the distended veins along the scalp, and then you see something called sunsetting of the eyes, or a downcast gaze, because when the hydrocephalus gets big enough, it affects a part of the brain called the tectum, which is responsible for some of the eye movements. And one of the most common eye movement disorder that we see is that downcast gaze. So if you see a kid with a big head, distended veins on the scalp, a downcast gaze, that's a problem. That's a problem, and we have to fix that problem by dealing with the hydrocephalus. This is different than the craniosynostosis, and we'll get there. Microcephaly, it's the exact opposite of hydrocephalus. Okay, with microcephaly, what we're dealing with is a brain that is not growing adequately, and there can be various reasons. There can be a viral infection that can cause that. There are many reasons for children to develop microcephaly. Some of them are genetic, and really, these kids don't do so well. They have significant, most of them have significant developmental delay, but that's not so evident really early on, right? Because when you're a baby, all you're responsible for is eating and smiling and making eye contact. And many times these children will eat and smile and make eye contact, but gradually the children will drop off in terms of their developmental milestones. So they won't be sitting independently by 8, 10 months of age. They won't be standing. They won't be walking by or talking by a year. Those are developmental milestones that we look for when we see children growing. But back in 1894, people didn't understand this because we didn't have MRI, we didn't have CT scan, we couldn't really look in the brain. And people would confuse microcephaly for a prematurely fused skull, meaning a skull that was not allowing the brain to grow. Okay. And that just was not the case. And, we talk about peer review, like there's a whole process of peer review whereby we look at what others in our field are doing, and we make sure that what they're doing is safe and appropriate. The hands too frequently take the place of the brains. Who does not know that the alleged safety in operating tempts some skilled operators and the credulous public into useless or even contraindicated procedures? Is it sufficient glory to let daylight into a deformed cranium and on top of a hopelessly defective brain, and to proclaim success because the victim consented not to die of the assault? Such rash feats of indiscriminate surgery, if continued, moreover, in the presence of 14 deaths in 33 cases, are stains on your hand and sins on your soul. That's real peer review. And that was written in a time period where surgeons were opening up the skulls to make room for a brain that had no intention of growing because it was defective. And so microcephaly is still to this day commonly confused for craniosynostosis. And I see a few dozen consults every year of kids with just small heads because of microcephaly, and pediatricians want to know, should we do anything about this? And there's nothing to do. So just identifying it is the issue. So take-home message number one: the skull grows in size and shape to accommodate brain growth. So if we look at the normal skull of a newborn and we look at the fontanelle, and remember I spoke about the brain constantly producing fluid, what we're seeing here is we're seeing the heartbeat through the fontanelle. So every time the heart beats, blood rushes into the brain expands just a little bit because of that blood, and the fontanelle will pulsate, and that's a normal thing. So the fontanelle is not its own thing, right? The fontanelle is actually an intersection of what we call sutures. And sutures are cartilage, and cartilage is what forms bone. So as the brain grows, the skull grows along the metopic suture, the coronal suture, okay, the sagittal suture, the occipital bone, the occipital suture, the lambdoid suture rather. And there's these intersections of sutures called the anterior and the posterior fontanelle. And the anterior fontanelle is the one we all see. We call it the soft spot, right? When if you've had siblings or or cousins that are tiny babies, you put your hand on their head and there's a soft spot there. So the soft spot over the course of time becomes smaller and smaller and smaller. And this is kind of a graphic to indicate that in the newborn, you've got two big soft spots, right? You've got the anterior and the posterior fontanelle. By about 6 months of age, you can't really feel the posterior fontanelle. By about 2 years, you barely can feel the anterior fontanelle. And by 3 years, you normally don't feel the anterior fontanelle. But is it gone? No, it's an intersection. It hasn't gone away. It's just gotten so small that you can't feel it. And that's normal brain growth. The sutures are all open because remember, the brain continues to grow and therefore the skull has to continue to grow. So take home message number 2, the fontanelles are intersections. And again, a few dozen times a year, maybe even more, I get consulted on a child because the fontanelle is prematurely closed. That's not really a thing, because if the fontanelle was prematurely closed, it would mean that 1, 2, 3, 4 sutures would be prematurely fused and skull growth would stop and the brain would just push it upwards. So that just doesn't happen. So there are a number of things that can shape the skull, and there are external forces that can shape the skull. And actually the most common form of a misshapen skull is something called positional plagiocephaly. And basically, it's because children tend to lay on one side of the head more than another on occasion. And when we have positional plagiocephaly, it's an external force onto the back of the head that pushes everything forward on that side. That can be made worse with something called torticollis. And torticollis is where you have your head stuck to one side because of a tight neck muscle. And that could be related to how you're stuck in the womb, or how baby's stuck in the womb, or birth related manipulations. So there's lots of reasons that kids develop torticollis. These days, kids are put to sleep on their back. Okay, and when kids are put to sleep on their back, it promotes that. And we'll talk about that and why in a second. But when we have positional plagiocephaly, to the left, we see this parallelogram effect. Okay, so this is an external force that's pushing everything forward because the baby's laying on this side of the head, as opposed to a prematurely fused suture, which will create a different head shape. And we're going to get to that, but that's another source of consultation with misshapen heads. I see it all the time for these children with positional plagiocephaly, and there's nothing to do from a surgical standpoint. Sometimes we'll put the kids in a helmet, but we just basically instruct the parents how to adequately stretch out the neck and how to get them moving in the right track, because that normal brain growth wants to make a normal shaped skull. This is what I mean by torticollis. And if you see a kid with their head cocked to the side and turned the other way, that's very typical of torticollis. And it's very difficult to keep kids on the other side of their head if they're stuck in this direction. Then we have those kids that sometimes are stuck straight up in the air. They're lying on their back and they just are so comfortable under the direct back of the head. And this is fine. This doesn't really cause a significant cosmetic deformity up front, but it causes flattening in the back. This is called positional brachycephaly. And it's more common in some genetic populations than others, and it's more common in terms of the way certain populations swaddle their children, but this is a very common thing. It creates a wider head, but there's no problem with the facial symmetry. So when we have a problem with facial symmetry, sometimes we just do neck stretching and repositioning, and other times we put those children in molding helmet therapy. And this is molding helmet therapy. What we see here is this is a child with a flattened head, and after 3 months of a molding helmet, they look like this. Why 3 months? Well, because basically the way these helmets are built, the amount of padding that they have usually lasts about 3 months of brain growth, right? Because the padding has to be shaved down to allow room for this. Otherwise, it would get really tight within a few weeks. So you go back to the parents bring their child back to the orthotist, who's a helmet specialist, and that helmet specialist will shave down the internal foam in the helmet just to create the shape. And this is something that we use quite a bit, both in positional plagiocephaly as well as in craniosynostosis care. So you can see if you've got a big head and you're just lying flat on it, it's going to become flat. So we tell parents tummy time, tummy time, tummy time. You can't do enough tummy time. And we also teach parents how to do neck stretching exercises, and I generally recommend them to be done with every diaper change. That's about 9-10 times a day, where we're stretching out the neck, we're getting rid of the torticollis, we're getting the kids off the flat spot. Getting them up into devices like a swing is terrible. They're strapped in, their head is resting on something, and that's a problem for these kids that develop flat heads. But the exersaucer, for example, where they're upright and their head's not resting up against anything, that's a lot better to allow that normal brain growth to round out the head. And parents get really creative with these helmets. So take home message number 3. Since 1994, the Back to Sleep campaign of the American Academy of Pediatrics really has created a nation full of misshapen heads, but probably for a good reason. That was to prevent SIDS, sudden infant death syndrome. And what we found was that the incidence of SIDS dropped down since the Back to Sleep program. But what we've done is we've created a much more of a rate of positional plagiocephaly and positional brachycephaly, but probably for a good reason. The SIDS rate has declined clearly since that time. Some of that is due probably to this Back to Sleep program, and some of it's probably due to recognition of other causes of infant death. So tummy time, tummy time, tummy time. Okay, is really, really crucially important, but we don't tell parents to put their infants to sleep on their stomach. It's fine once they do it on their own. If they go to sleep on their back and they flip over onto their stomach, no problem. Okay, they're old enough and they're developmentally advanced enough to do that safely. But we always tell parents to put their children to sleep on their back just to prevent SIDS, and that can cause this problem. So we supplement their positioning with increased tummy time when they're awake. So really, when an infant's awake, in order to fix that problem, on their tummy all the time, playing awake. But when they fall asleep, they got to put them back on their back until they're able to do it on their own. So infinite supervised tummy time, neck stretching with each diaper change, eliminate the swings and bouncy seats, and just patience. Why? Because we got to let the brain grow. So there are other things that cause lumps and bumps, and other things that cause lumps and bumps.
I know, you keep looking at.
I apologize. Misshapen heads, and so there are growths that can occur in the skull. And this is an example of something called a dermoid cyst. Basically, skin cells trapped underneath the scalp that grow in certain areas, often by the fontanelle, often by the sutures, and it grows under the skin. And these are common things that we take care of. We do, hundreds of these a year, where we just make an incision in the scalp and lift this from the skull, sometimes from within the skull, and it allows normal healing, and generally speaking is curative. But there are other problems that can occur from the skull. This is something called biparietal foramina. These are holes in the skull due to pulsations of cerebrospinal fluid and blood flow. And there's nothing we need to do about them. They just get smaller over the course of time, generally speaking. But there are other things that can cause problems with skull shape and other lesions. Neurofibromas, fibrous dysplasia is a benign growth in the skull. Osteomas, osteoid osteoma, ossifying granuloma, giant cell tumors, aneurysmal bone cysts. These are benign lesions of the skull. But there are also malignant lesions of the skull, neuroblastoma, lymphoma, Ewing sarcoma, osteogenic sarcoma. And some of these require really extensive surgery to get rid of them. And some of them are exquisitely sensitive to chemotherapy and radiation. So often in these cases, we'll do a biopsy to see what things are and see what the best course of action is. And in pediatrics, and you've probably heard this before because John Bookvar is really, really into getting people enrolled in trials, and it's such a great thing. In pediatrics, almost the vast majority of cancers, especially brain cancers, are placed on a protocol. They're studied. They're entered into larger centers that are collecting data. So we get a lot of information on that. It's and the tumors that we see in childhood are a lot more differentiated, at least from the brain standpoint, or a lot more varied rather than some of the stuff we see in adults. In adults, there are not that many types of brain tumors that occur frequently. In pediatrics, there's a really huge type or list of brain tumors that occur frequently. And in fact, brain tumors are the most common solid tumors of childhood. So we see a lot of that. And that's a whole other talk, and I'd be happy to give a brain tumor talk to you guys if you ever want. But there are other things on the skull that cause lesions, cephal hematomas, which is a blood clot between the skull and the lining of the skull. And if they're left alone, they can calcify and form a bump that just stays there forever. It'll get smaller over time because the skull gets bigger, but that bump will always be there if it calcifies. Leptomeningeal cysts are non-healing skull fractures. So there's lots of things that can occur. This is an example of a cephal hematoma. And this is a child who was born with vacuum extraction at the time of delivery and has a collection of blood under the scalp. And what happens is the parents become so afraid to touch it because it's squishy that nobody touches it, right? And if nobody touches it, what happens is gradually it picks up calcium and it solidifies, and that bump becomes a solid second layer of skull. And if it's really bad, sometimes we'll operate on that, but we try not to. So when I see them early enough, I tell parents, you've got to massage this. And to teach parents to massage a bump on the child's head is very stressful to them because they think that they're going to hurt the child when they're not. This is outside of the skull. So a lot of what I do is educational. And we can see here's an example of a cephal hematoma. And this one is associated with a very, very small skull fracture that you can see right there. Okay. This is what happens when it calcifies. Okay. So massage cephal hematomas to prevent calcification. So we have all sorts of skull fractures that we see in children, and we're really mostly talking about infants. When an infant gets a skull fracture, sometimes the lining of the brain or the dura mater is torn, and that creates something called a leptomeningeal cyst. And I can do a whole trauma talk if you guys want also, but leptomeningeal cyst causes abnormal cerebrospinal fluid circulation locally and actually causes a cyst within the brain. So this outer skull fracture causes the fracture. This outer skull fracture doesn't heal because cerebrospinal fluid is leaking out into it. The skull fracture gets bigger, a cyst forms, and we have to repair that surgically. Then there are skull fractures that we call ping pong fractures. So if you took a ping pong ball and you depressed one side of it, you'd get a ping pong fracture. And that's exactly what this child has, is a ping pong fracture. In this case, this was a child that was delivered manually, with some assistance and some distraction. And there's literally a thumbprint in the thin skull. And the way we fix that is we can drill a little hole on the very side of it. It's a very minimally invasive operation. Drill a little hole on the very side of it and just push it out like a car dent. Or I've even attached a vacuum pump, a breast milk pump to the head by way of just adding some lubrication around it to create a seal and sucking it out, just like you would a suction cup on your car door panel. And so here you've got just examples of what we call ping pong fractures. Moving right along. So let's talk about the real meat of this, which is craniosynostosis. And craniosynostosis is premature fusion of the sutures, as I told you, and it happens in about 1 in 2,500 births. It's mostly sporadic. There's about a 2% familial incidence for sagittal craniosynostosis, meaning that if you have a child with sagittal craniosynostosis, your chances of having another one are slightly increased. And the same with coronal craniosynostosis. Overall, the majority of these patients are male, with the exception of unilateral coronal or coronal craniosynostosis one side, which is predominantly female. So in 170 AD, Galen coined the term oxycephaly, oxy meaning sharp. It wasn't until the late 1700s that somebody decided, oh, you know what, we think that skull growth occurs along these cranial sutures. And in the mid 1800s, Virchow proposed that skull expansion occurs perpendicular to the sutures, or to the prematurely fused sutures. And it was in the late 1800s that people decided to operate on this to release a prematurely fused suture, around the same time that there were unnecessary operations being done. So this is normal skull development. Cartilage forms by the 7th week. So before a woman knows that she's pregnant, the cartilage of the skull is already forming. By the 3rd month of pregnancy, the cartilaginous skull is in its height of development. And then subsequently, all of that cartilage forms bone, with the exception of the sutures, which remain separated. So after a child is born, the fontanelle really decreases in size rather dramatically, as I told you. And by about 8 months of age, we're really not feeling much of a fontanelle. Skull growth really stops at about 10 years of age. You know, if you bought a baseball cap at age 10, it would be a little tight on you as an adult, but not dramatically. The complete ossification of the skull, where all the sutures actually fuse, really occurs in your 20s and 30s. So a long time before those sutures completely go away. So let's talk about skull growth after single suture closure. And the graphic is a little busy here. We'll get to each one of these individually, but let's go through them here. So if the metopic suture, and in all of these cases, the head is pointing up, right? If the metopic suture fuses prematurely, that's here, okay? The skull can't grow laterally here. And what we see is we see this type of skull growth. Okay, you can see my picture here, this type of sharp skull growth. And we call this Trigonocephaly, or triangle head, one of the more common ones. And what we do for that is, well, you'll see what we do for that, but we release that prematurely fused suture, I'm sorry. For sagittal craniosynostosis, it means that this suture is fused prematurely. And for that suture being fused prematurely, the skull elongates and it grows this way, like this. So an elongated skull because of the prematurely fused sagittal suture here. Okay. So for coronal craniosynostosis, we have this, in this case, the left coronal suture is fused prematurely. So what happens is you get a flattening here because this area of the skull can't grow forward. And that's what we see when we look at this skull here. And we're going to see examples of each of these and what we do for them. So the bottom line here is that growth perpendicular to the suture ceases when it's prematurely fused, but there's a compensation that results because the brain continues to grow. So that compensation allows prominence in other areas of the skull. So let's talk about sagittal craniosynostosis. So that's that midline premature fusion. And if you look at the top of my head, I have a little ridge along the top of my head. I probably have a little partial sagittal craniosynostosis that was never taken care of, but my overall head shape seems to be pretty normal as far as I can tell. At least my family tells me it's pretty normal. But if we look at that middle graphic of the fused sagittal suture, we can see that the skull is going to compensate by growing both anteriorly and posteriorly and not being able to grow this way. And we can see what that shape looks like there. And if we look at a three-dimensionally reconstructed CT scan that I've spun around here, you can see that we've got that elongation of the skull, and clearly the surgery is going to, clearly fixing this is going to be surgical, and it's going to depend on us releasing that prematurely fused bone. How do we do that? Well, here's a child in the operating room. You can see the problem here. And we'll get to the actual surgical corrections. Scaphocephaly, by the way, which is what this is called, is boat head. That's what scaphocephaly means, and that's the elongation of the skull secondary to sagittal craniosynostosis. But when you're starting out, all of a sudden you graduate and you're a pediatric neurosurgeon. This is what you envision, but this is kind of more reality. My family wouldn't let me name a boat scaphocephaly because they thought nobody would tie up next to us. So in any case, Trigonocephaly, or triangle head, right? We can see that here. This is secondary to metopic craniosynostosis, and in its most severe form we can really see the abnormality here. There are more subtle forms. There's some ridging that can occur along the metopic suture that doesn't need surgery, and a lot of my practice, I see a lot of children that don't need anything done, and just parents that need reassurance that this is going to normalize and settle down. But in this case, this child does need a surgical correction for that. Some other examples of trigonocephaly in reconstructed CT scans. But this is what I'm talking about a metopic ridge without trigonocephaly. We see this all the time. Probably some of you have this or had this as a baby, and just a ridge along the metopic suture. And the metopic suture, I like to call that a sticky metopic suture rather than a fused metopic suture. So what we see here are a number of kids that just have normal head shapes, but a sticky metopic suture. Okay, so not all ridges need surgery. That's take home message number 5. Okay, there's lots of questions coming up here, and I don't, we really should wait on them, but some of them are particularly good questions. So do these deformities require surgery because of functional deficiencies in the future, or is it purely cosmetic? And for the most part, single suture craniosynostosis, for the most part, is mostly cosmetic. Now, there was a study done in France back in the 1990s looking at sagittal craniosynostosis and comparing the intelligence quotient, so the IQ, of patients that had that repaired before a year of age or after a year of age. And it seemed that the patients who had it repaired before a year of age had a slightly higher IQ. There's so many biases built into that study that I don't really trust it. And I never use developmental delay as a real reason to do this operation, because we just don't know. With multiple suture craniosynostosis, where it's more likely that we don't have adequate skull growth, then I think it is more likely to see developmental delay. That was a particularly good question, but there's a lot of other good ones there, but we're gonna keep going here. So let's talk about plagiocephaly. This is anterior plagiocephaly. It's the front, so prematurely fused coronal suture here. And what we see here is the problem. Now, when we look at this, when you look at a child with coronal craniosynostosis, because of the compensation, this area here appears larger than it should. And everybody focuses on that area as being the abnormal area, but that's not. The abnormal area is the flattened orbit here, or the flattened eye socket here. And what we do when we correct this is we have to really even out the eye sockets here. And we actually bring out that eye socket. And you'll see that. Here's an example of plagiocephaly, and we can see which is the abnormal side here. Well, it's this one. This is the abnormal side. The prematurely fused coronal suture prevents the skull from growing this way. And what we see is that deformation, which is this one here, right? You saw this slide before. So here's another example. This is a left coronal craniosynostosis. If we were to get an X-ray of that, we would see the abnormality in the shape of the eye socket. Okay, and so here's a kid, which is the abnormal side. Well, the abnormal side is the child's left side, and you're going to see that right now as he looks down. We can see how flat this is. the prematurely fused suture. Okay, so we can see that that's really the problem here, and this child needed surgery for that. Another example of this, and if we see this from above, we can see, look how effectively he can look up even when looking down. He's got right coronal craniosynostosis, the opposite of the other child, right? So, well, what do we do for that? Well, we take off the frontal bones, okay? We take off what's called the orbital bandeau. Okay, we straighten out the orbital bandeau. We use absorbable plates and screws, and we place it back. And generally speaking, this type of operation we do in late infancy. My favorite time to do this operation is around 9 months of age, but I'll do this operation anywhere between 6 and 12 months of age. Before 6 months of age, we have a whole different opportunity. So when and we'll get to that, but it's really kind of important to get this diagnosis made as early as possible, because what we want is we want to maximize the normal brain growth to shape the normal skull. So there are a whole bunch of craniofacial syndromes, and this kind of gets back to the functional deficiencies or the intelligence deficiencies. So Crouzons, Aperts, Carpenters, these are all of the kind of the listed genetically based deformities that happen because of craniosynostosis. So for Crouzon syndrome, what we see is maxillary hypoplasia. So the facial bones do not come out, and because of that, and because of the craniosynostosis, we see exophthalmos. The eyes look like they're bugging out. It's multiple suture involvement, but about 90% of these kids are cognitively normal. Now, cognitively normal is a little bit of a misleading thing, because that means an IQ greater than 80. Okay, and so the chances of any of you on this webinar having an IQ of 80 are pretty small. So 100 is what we consider the norm. So some of these kids are delayed, but it's the minority. And we can see these are examples of children with Crouzon syndrome. Most of these abnormalities are limited to the face for the most part, the face and the head. So when we operate on that, we take off that orbital bandeau. There's the orbital bandeau, and we reconstruct it. We'll get more into that. Aperts, we can kind of consider similar, but opposite. With Aperts, their head shape is more severe. They have a high forehead, a flat occiput. They've got a persistently open anterior fontanelle. They've got bicoronal craniosynostosis. They have orbits with upwardly slanting roofs. They've got eyes that are too far apart, called hypertelorism. And they have craniosynostosis at the skull base, which is underneath the skull. They have craniosynostosis. So inside the eye sockets at the skull base, as opposed to just the vault, which is the top. But these kids, less than 10% of them are cognitively normal. These kids, for the most part, have real significant developmental delay. They also have other abnormalities. They've got abnormalities of their digits, both on the hands and the feet, and of their teeth. So these require lots of intervention to get them as close to normal as we can. So here's an example of a child with Aperts. He's a relatively mild Aperts kid, but he's got deformities of his hands as well. Okay. And then there's just severe cloverleaf skull deformities, and these require multiple surgeries. They're very rare. Most of the time in developed nations, these don't make it to delivery. These are really severely deformed children that also have hydrocephalus and developmentally are devastated. So we spoke about the developmental delay associated with hydrocephalus. Sometimes we take off the skull because we're operating for craniosynostosis, and we see this copper beaten appearance to the inside of the skull. And that tells us, hey, this kid was probably dealing with raised intracranial pressure to some extent. And it kind of supports the fact that we needed to do the operation. But this is a minority. Most of the time we don't see this. Okay. So how do we do let's say a sagittal craniosynostosis for these kids? This kid's about 10 months of age. And we do a wavy incision or zigzag incision because eventually when this kid has a normal head shape, we don't want the hair to part on a scar when they go in the swimming pool with their friends, right? We want to hide that hair. So by doing this wavy incision, you can't really see it. It's mostly invisible unless you're really, really looking for the scar. And so after we do that wavy incision, this is the skull marked out, and here's the prematurely fused suture. Remember, the patient's head is facing down. So these are the coronal sutures here. This is that occipital keel, the back part. You can't really see the lambdoid sutures, but here they are, and they're normal. So the only suture prematurely fused is this one. So we take that out, we take bones on each side of that, we bring those bones back towards the midline to provide some protection. And we do what we call barrel stave osteotomies. So we make cuts, finger-like cuts in the bone here to allow the normal brain shape to push this out. And immediately at the end of this operation, we have a correction. We have a correction. We have a decreased anterior posterior dimension. We have an increased lateral dimension. It's immediate correction. Problem is, it's a big surgery, right? It's a big surgery. There's blood loss associated with it. A significant percentage of these children will require a transfusion, which in and of itself is extremely safe these days, but it's still a transfusion. And it's a big operation to put a child through, as you can see. But these kids do great. They have normal lives. They have normal intelligence. They have normal, it's extremely rare for them to require further surgery for this. So immediately on table correction, we go from this to this, which is pretty impressive. And then, at the first post-operative visit, the hair is growing back. You can see the zigzag incision, and this child did beautifully. Another example of this, the kind of dramatic corrections. And these dramatic corrections, they're great. This is a bit of an older child. This child is, I think, 2. And we can see the entire incision being made. This is a electrocautery used to open up the deeper layers of the scalp. And then we dissect out. In this case, we took off one large piece of bone. The operation itself generally takes us about 3 hours or so, sometimes 4 hours, depending on what we're doing and the age of the kid. And in this case, we did these barrel stave osteotomies. The barrel staves, if you look at a wine barrel, right, it's made up of these pieces of wood that are bound together, but if you take off that metal band, they would expand out like that. And that's exactly what we're doing here, allowing that to expand, putting the bone back with sutures or absorbable plates, closing the scalp with absorbable sutures, and those kids do great. Here's another example of a different type of technique that we use, and this is this technique is distraction. So sometimes what we'll do is to create or fix a skull shape, or in this particular case, to create more room for the brain, we'll actually install these reverse vices, and the parents will turn them 1 turn a day, and it will just bring it out 1/2 millimeter a day. And we'll do that over the course of about 30 days, sometimes 60 days, to get the skull to move away. And then by the time that the expansion has completed, the stems are now internal. We can pull off this part of the stem. It heals with that reverse vice in place. The skull recalcifies to get larger, and then we go back in and we take out those vices. And this is a really specialized technique that I do in conjunction with the craniofacial plastic surgeons. Kind of cool stuff. We talked about these interventions often needing transfusion, but there are other things that we do in terms of surgical techniques that decrease blood loss, administration of tranexamic acid, TXA, to decrease blood loss. So there's things that we can do, but again, the blood pool is so safe that it is incredibly rare. I think the last statistic I heard was 1 in 6 million blood transfusions results in some sort of communicable disease, and it's probably less than that by now. So all blood is statistically, quite safe. That being said, parents always ask, should we donate blood for little Johnny? And the answer is, you should donate blood, but not for little Johnny. And the reason that I say that is if little Johnny, God forbid, for another reason needs a kidney or a liver or something, the person that little Johnny's going to look for that organ is most likely going to be an alive parent. So you don't want to have a child develop antibodies to their parents only for a blood transfusion, which is so low risk. Save that relationship for, God forbid, and even though it's rare, God forbid somebody needs a solid organ or some sort of thing, then you can start talking about that type of thing. So this is why I lecture on craniosynostosis, because in the ideal scenario, we try to get pediatricians to recognize these things really, really early. And the reason being is that we have other options when these are diagnosed certainly before 4 months of age, but ideally at around 3 months of age, where I can go in endoscopically with a minimal incision, really small incision. Usually I make it for sagittal, I make it right in the middle here, and I take off the entire sagittal, prematurely fused sagittal suture and helmet the child. And I don't do barrel stave osteotomies. I don't take off large portions of the bone. I don't need a transfusion. It's a half an hour operation, and the kid goes home the next day. It's a great operation, and we're doing more and more of that. But the only way to do that is if it's caught really early. So education is really important. And as you've recognized, information is so readily available. So imagine 20 years ago when, or probably more than that, 25 years ago, when the internet really didn't have the same good information out there. These were slower to come to a diagnosis. But now, parents can just Google head shape, while they're, sitting in a parking lot, and learn everything that they need to know about craniosynostosis. And so these minimally invasive techniques are growing in popularity throughout the world. Certainly in my practice, I do a tremendous amount of this, where we go in and remove that prematurely fused suture and then subsequently get the child helmeted. So here's an example. That same sagittal craniosynostosis operation that I just showed you, I do through an incision that's essentially 3 centimeters wide. And I'm able to get the prematurely fused suture all the way from here back to here, removed just with one small incision at the top of the head. For a metopic, I do the same thing and can go all the way down to the nose, and subsequently helmet these kids. These dots, this is a dot of the anterior fontanelle, so I know where it is, and that's my proposed incision. And so this is 2 weeks after minimally invasive endoscopic removal of the sagittal suture. So this is the original molding scan for the helmet. And subsequently 6 months after the final helmet. So there's 2 helmets, each one of them lasted 3 months. This is the kid's final head shape with a scar that's just that long. So really well done. This parent just made this framed picture for me. And on the bottom, you see how he was when he got to me. And how he is now, and you can't see an incision. He's just got a perfectly shaped head, developmentally normal, no incision. In general, I like to do that operation before 4 months of age. After 4 months of age, it's a little less effective, and my rate of needing a secondary operation for these children increases. So the sweet spot for me is 3 months. If I can do this at 3 months of age, most of the time I can get these kids through with only one operation. But it varies from suture to suture. And the reason it varies is it varies in terms of how effective the helmeting is. Okay. And so for a sagittal, the helmet's really effective. So almost none of those kids require a secondary operation. For the metopic, the helmeting is a little more difficult because the only place that the helmet can touch is really down on that nasion region, because we want this to expand here. And those kids probably have about a 30%, 20 to 30% rate of needing a secondary operation for correction. And it varies, obviously, depending on how well the helmet fits. Okay, so I wanted to save 5 minutes for questions, and there are a number of questions that have already been on the chat. So if you don't mind, I'm going to go backwards a little bit and answer some of these questions from the chat. Oh, there's a lot here. Let's see, lots of good mornings. Somebody wants to, okay, could microcephaly be related to fetal alcohol syndrome? Absolutely, yes. Can this be treated with helmet therapy? I'm not sure what that was in reference to. Is it common to get a cephal hematoma when vacuum extraction is used? Not particularly. How is SIDS related to brain growth and child sleep positioning? Nobody knows. Nobody knows. It's a great, that is the $100,000 question. We don't know why. Is it suffocation? We have no idea. Breech babies born with skull elongation like that, how long do you wait until it's a problem? Great question. This is very different than the molding associated with birth presentations. And so sometimes I'll see like a 1-day-old and I'm like, I don't think things are prematurely fused. But in those kids, what I can do is I can just press on their head and see if the bones move in relation to each other. It freaks parents out, but the head's squishy, right? You can move the bones and see if they're prematurely fused. And most of the time I'm able to tell a parent yay or nay, it's fused or it's not fused. Sometimes I'm not sure, and I'll say, why don't you come back in 6 weeks? Let's see what things look like then. So that's a great question. Functional deficiencies I went through a few times. Optimal window for skull surgeries. So endoscopic 3 months, open 9 months, just if you have to remember anything. What causes these genetic, we don't know, but we do think that there's a genetic component to this, but not a direct, not necessarily a direct identifiable mutation. How long does it take time to do the operation? The minimally invasive endoscopics takes me under an hour. The full vaults take me 3 to 4 hours. Long-term effects on bone growth, not sure what that was. Expanders and orthopedics, that's exactly right. Can a neuroplastic surgeon, okay, so the whole concept of a neuroplastic surgeon is relatively new. And I think you've had a lecture by one, and it's kind of cool stuff, but I kind of consider myself a neuroplastic surgeon because of this type of stuff. The way a neuroplastic surgeon is being used in this context is a neurosurgeon who does some additional training in plastic surgery. That's my whole life as a pediatric neurosurgeon. So, I think the answer to that is yes, but a neuroplastic surgeon, the way it's used today, are not pediatric neurosurgeons. So they don't do these operations. They do similar types of things in adults. At least that's the desired effect. And there are not a lot of neuroplastic surgeons because it's a relatively new thing that they created at Johns Hopkins, and I think we're seeing more of it. A lot of people, it's creating a lot of interest. Somebody said to donate blood. What age endoscopic surgery? I answered that. How does my work differ from a craniofacial plastic surgeon? That's a great question. So craniofacial plastic surgeons cannot do craniotomies, right? They can't remove bones from the skull because of the underlying brain. So in general, most of these cases and all of my open cases are done in conjunction with craniofacial plastic surgeon. I've got these great craniofacial plastic surgery colleagues, some of whom may have given you guys talks, and they can do all sorts of cool stuff. Generally speaking, when the skull bones need to be removed, that needs a pediatric neurosurgeon. But in terms of the reconstruction, in terms of reshaping the orbital bandeau, I probably didn't give my craniofacial plastic surgeons enough credit because they're the ones that actually reshaped that bandeau. And I apologize for that. I'm really glad that you asked that because I do have, great relationships with craniofacial plastic surgeons. Common areas of research in pediatric neurosurgery, you name it. We've got brain tumors is a very common area of research. I think as we see more and more genetic research going on, I think we're going to see a lot more research focused on that. Certainly, we're seeing that in brain tumors. Hydrocephalus research, very common. Can microcephaly be identified in utero? And if it can, how do you distinguish it from anencephaly? When anencephaly is it's open. Like, so you're looking down at the abnormally formed brain and you don't have closure of the skull. So they're very different. Is your job title peds neurosurgeon, or do you specialize within peds? So that's a great question. I am a pediatric neurosurgeon, which requires a fellowship to be done at a children's hospital after your neurosurgery training. And each of us have our areas of expertise. Like Sean Rodgers, who you heard last week, his area of expertise is pediatric epilepsy surgery. That's what he loves to do, and he does a great job of it. I was trained to do it as well, but I don't focus my practice on it. So most of us in pediatric neurosurgery can do a whole wide variety of things, but my thought is there are certain things that I do really, really well, and there are certain things that I've identified other people that do better than me. And I think that the humility of being in this type of field, you have to identify, who's got the skill set for what, and make sure patients are getting to the proper care. So that's actually a great question, but I'm available to do anything. I think we're out of time. I think we've answered almost every question here.
Yeah, that was great. Thank you so much for your time, Dr. Mittler.
Awesome. Thank you so much for having me.